Here's another case in this category where we initially were planning to save the first molar. You see there's decay on the distal. We did a healed site placement in the upper right second molar, and then after we changed the healing abutment to give the doctor access for the decay on the distal of the first molar, at that point the decision was made to remove the first molar. So now we're going to have an immediate placement in the first molar site, and we're going to want to splint it to the previously placed implant in the healed site. Here we're going to try this time to put it in the middle, because I don't want to create a pontic space here. I want to try to have two molars splinted together, and I know for mesiodistal spacing, if I can get that molar mid-root, we're going to have a better prosthetic result. Here's after several months of healing, and here's 6 months after the restoration is done, and here's 3 years after the restoration was done. And you can see our contours here from the palatal view, and here from the buccal view. I'm sorry, we've cropped off a portion of the second molar. We have more normal size looking molar teeth without the pontic. So next category in this category B of good results, immediate molars with narrower implants, is the same situation but in the mandible instead of the maxilla. Here we're going to remove this bridge, and we're going to do an immediate implant placement in the bicuspid, and we're going to do an immediate in the molar site. So the question is, excuse me, we did not remove the bicuspid. We're going to do an immediate implant in the previous pontic site, and that's the healed site, and we're going to do an immediate placement in the distal root of that extracted molar. Obviously, I'm going to go in the distal root as opposed to the mesial root, so we can have some space in between, and we calculate that we can restore this as a 3-unit bridge with the previous mesial root site of the extracted molar being the pontic. So that's after healing. That's in fact what was done, and here we have what looks like a 3-unit bridge. So these kind of cases can work out extremely well. Another little category is, what about when we have to remove all the teeth? And I often do these kinds of cases, believe it or not, as full mouth extraction and full mouth immediate implant placement. And sometimes, as in this case, the lower distal implants are in the molar extraction sites on the patient's left. This would be in the distal root of the lower left first molar, and on the right in the distal root of the lower right first molar. And the others were single root placements. Here is another case. Similarly, as part of this full mouth reconstruction, on the lower left we have an implant in the mesial root of the first molar. That's the distal implant there. On the patient's right, the distal implant is an immediate placement in the distal root. So we don't always have to go intraradicularly. We can often go in the socket itself if we have other implants we're splinting to, and we have more flexibility in creating pontics where we need them and make it all work out prosthetically. Now here's another category under the B section where we have 2 implants, both immediates, splinted together. The previous one was an implant placed in a healed site, splinted to an immediate. Here we're going to do 2 immediates, and where do we put these implants? In the socket, interceptally. Well, we're going to remove these 2 molar teeth, the lower left first and second molar, and here we place the first implant in the mesial root of the first molar, and again in the mesial root of the second molar. And anticipating that again we can do probably a 3-unit type bridge with a pontic in the middle. As it turns out, the way this restorative dentist and this lab chose to restore this case, they've kind of over-contoured the aspects of both crowns, creating a 2-unit restoration with a rather large interproximal space between. And this may be perfectly satisfactory for 99% of your patients. If this space or food impaction problem was an issue, perhaps utilizing a pontic would have been a better restorative decision. Now here again is another category as in the maxilla, same as the mandible. In this case, we already have a missing tooth, and you see the pneumatized sinus here. Again, planning in advance, if we were to remove these teeth and wait, I think we would not be able to do an implant in the molar site without a sinus graft first. By doing immediate placements in this case, both in the bicuspid anteriorly and in the molar posteriorly, we were able to manage to capture the buttress of bone in the bicuspid placement and sneak it along the distal wall of the sinus without the need for sinus grafting. Probably when you think of immediate implant placements in molar sites, you think more often of the single implant, the single molar, which is perhaps the most common situation. And here again, in the maxilla, we more or less have two categories, again, whether you place the implant in one of the root sockets or whether you place it mid-socket intraradicularly. The potential advantage, like before, of going in the socket, it's easier to get initial stability, smaller peri-implant void to deal with. And the advantage when you go in the mid-socket is that you probably have a better implant positioning. Potential disadvantage of going in one of the root sockets is you probably have compromised angulation. You may have an unsupported portion of the tooth if you're not in the middle of the tooth. And the possible disadvantage if you go mid-socket is that you may not be able to get good initial stability. If you've drilled away your interseptal bone, there may not be enough stability depending on the type of implant, diameter and shape you have. And sometimes if you put the implant right in the middle of a molar socket, you've got a rather large peri-implant void to deal with. So let's look at the first category where we're doing a single maxillary immediate molar placement, and we're going to put the implant in one of the sockets. And here's an example of a molar to come out. The implant is placed more so in the distal position, and while the results are really not too bad, you see the healing here at 4 months, we do have an implant that is angled. Honestly, with an implant of 5 to 6 millimeters, I'm not worried biomechanically that we're not exactly along the long axis of the tooth. But we may have some issues here with the interproximal anatomy, with a larger interproximal embrasure mesially that may be more prone to food impaction. Generally a good result, but perhaps not optimal. Clinically, it looks quite nice. What about when we're doing the immediate maxillary single tooth restoration and we are able to place the implant more in the center, as in this case it's more in the center. This one's a bit shallow actually, so we have a short root, but you can see that we have a more optimal positioning of the implant, even though we probably have too much tissue here and a short crown. What about in the mandible? Again, same two categories. What happens when you place the implant into one of the molar sites? Here we're going to place it in the mesial root of this molar, and you can see that we try to distalize it as much as we can, and perhaps you might end up with a bicuspid size restoration. In this case, this was a wide diameter implant that we were able to put a tooth that was almost a full molar size, and the patient didn't have an opposing second molar, so it was a very satisfactory restoration. Here's again just another similar case with a different implant design. And again, this case, the tooth is closer to bicuspid size. So sometimes we have to accept a smaller restoration size, but that's perfectly adequate in many cases. Well, what about when we can put the implant right in the mid-socket? And here's a case where we're going to do that. And again, all these implants are what I'll call narrower, meaning 6 millimeters or less. This is a 6x13 where I managed to get it pretty close to mid-root. And we have what I think most of us would feel is a pretty acceptable result. And we have very nice clinical results as well. The problem here is we can't always get good initial stability. And sometimes we do run into some non-ideal results when we're dealing with these implants that I'll call narrower, i.e. 6 millimeter diameter or less. So here comes the fun. Let's look at some compromise results. And the categories are very similar to the previous categories we looked at in terms of what the considerations are. Do we have compromised results sometimes when we go in one of the roots versus the other? Do we have compromised results sometimes when we place the tooth intraradicularly? We have a different set of challenges depending where we position the implant. Let's look at some examples. I think this is an important one. We are going to place the implant mid-root, but we're going to have problems with gaining initial implant stability. This was a molar that you can see the fracture on the occlusal surface. It ran all the way down the root. That's why we had to take it out. We have a fused molar in this case, so basically we have a big hole, a big extraction socket space. There's no intraradicular bone. And with standard narrow diameter implants of 6 or less, and this is the drill for a tapered implant of 6 millimeter diameter, 16 millimeter length. As you see in my letter on the considerations and suggestions, I say there this case was quite difficult to achieve stabilization. In fact, the implant was not very stable. And in fact, this was a big problem with any implant. And you'll see that we did restore the case, but that's not the implant I placed, i.e. that first implant failed. And it failed because, in my opinion, we did not have good initial stability. It turns out we let it heal and we replaced it with an implant in a healed site. So initial stability is absolutely a prerequisite for successful osseointegration, and that can sometimes be a challenge. Other times we can get an implant in the interradicular bone, but we have to keep it narrow because we don't want to take all that bone away, and then we'll have no stability unless we have larger size implants. Problem is when we have a narrow implant relative to a big molar tooth, we have a discrepancy in what some people call tomato on a stick. So here's a tooth we're going to take out. There's the mesial and distal views of that extracted tooth. You can see we have some interproximal bone to work with, but the diameter of the implant is relatively small relative to the size of the occlusal table. So we get this emergence profile issue of, as I say, what some people call tomato on a stick. Here's another example of that. So wouldn't it be nice if we could get in a much larger diameter implant, perhaps 8 to 9 millimeters, where we don't have this problem with the emergence profile? But back to the narrower implants, what about when we go into one of the roots with one of these narrower implants? Then we have other problems with compromised position. Now this was a case I showed you previously. That's a healed site placement, but one that we had narrow width orofacially, a lot of room mesiodistally, and we ended up doing 2 implants that increased patient cost and frankly made oral hygiene more difficult. Well, what if we took out a molar tooth and put 2 implants immediately, one in each of the mesial and distal roots? It's probably going to be a disaster because it's going to be next to impossible to parallel them, and it's rare that you have enough mesiodistal space to be able to restore that properly. So I'm going to show you a very embarrassing case where I did place the implants, I didn't do the restoration, and you can see how this is certainly not what you want to see in your cases. I'll take that one off the screen very quickly. So here's a case where we're going to remove a molar here, the first molar, and we've placed the implant in the distobuccal area, and you can see again compromised implant position, perhaps clinically acceptable, but perhaps not ideal when we're doing placement right into one of the existing molar roots. Not a bad result, but again, you saw this in the intro. This works, but perhaps we have food impaction on the distal. Biomechanically, there may be some considerations, although with an implant this diameter, I don't think it's critical, but maybe not the best we could do. I'd rather see this implant placed mid-root than in one of the roots. And I show you this can get worse. Here's another example. I'm going to place an implant in the distal root here, and you can see that the angulation is much more significant. Now look what happened when the dentist called me up and said they couldn't get the crown seated. And look at the distal contact of that crown, and look how that molar has been adjusted or shaved to try to allow seating of this crown. So this is related to the path of insertion and the fact that the implant is not in the mid-root area with a straight emergence profile. Now, I think part of the problem here too is the dentist may have done a one-piece crown and abutment construction or UCLA type of restoration, whereas if they did a separate customized angled abutment and a separate crown, this problem could have been avoided. But certainly the angle of the implant was at least partially to blame for this situation, and eventually the case was modified, but we don't like to be knocking off the mesial aspects of our adjacent teeth to get our crown seated. Here's that case clinically. Well, again, there's a specific situation that we may not come across too often. Here's another case I did more than 6 years ago with the implant in the distal root, and it worked out fine, but actually if you look carefully, you'll see there's a little retained mesial root tip. Now, if we're using one of these large implants that I'll introduce to you in a moment, basically drilling out the interradicular bone, we'd be able to remove that root tip just through our osteotomy procedures, and that would be a nice advantage to get rid of root tips. In this case, it didn't matter, but sometimes we have root tips that may come back to haunt us. Other concerns when we're using the narrower implants in the mid-root placement is sometimes I do get concerned that the amount of space we have between the extraction socket and that implant is quite large, and that can impact on perhaps having a problem with the implant in terms of bone loss, or maybe we tend to sink the implant too far apically because we're worried about the size of that peri-implant void. Here's an example of a submerged deciduous molar, and you can see we have a fairly large peri-implant void, and we're using a standard 4.1 millimeter diameter intraosseous implant with a 4.8 occlusal surface. And the clinical result looks not bad, but when we look at the case radiographically, we'll see what the problem I'm getting at. We have the submerged deciduous tooth. Now look at when I place the implant, and there is already a 3 millimeter healing abutment on this implant. You'll see because of that wide peri-implant void, I tended to sink the implant a bit too far apically, just to try to get to a narrower portion where that peri-implant void would be reduced somewhat. And while the implant did integrate well, we pay for it in pocket depth. As Carl Misch likes to say, how deep do we place the implant? As deep as necessary for aesthetics, but as shallow as possible for health. So the deeper we're going to sink our implants in, we don't have to worry about metal showing, but we will get more pocket depth, and we pay for it on the health side of things. I also get concerned with maybe sometimes we're getting a little more bone loss when we have a smaller implant in a huge extraction socket. So on occasion, not too often, we'll see an implant that integrates well, but we may see bone loss down to the second thread, and sometimes I am a little concerned that long term we may be getting over 5 millimeters in pocket depth sometimes around these implants. So let's move on to something that you may not be familiar with, and that's utilizing these, I'll call them MAX implants from the Southern Implant Company, that they make implants of 8 to 9 millimeters in diameter that are specifically designed for immediate molar placements. And this is, again, a slide I showed you before, and you can see via the little diagram that these implants are tapered. They come in 8 and 9 diameter, and they come in 3 lengths, 7, 9, and 11. So let's look at some of these cases, and one of the issues you might ask is, well, when we do these immediate placements in general, should we submerge, or can we do them as an exposed protocol or one stage? Most of the ones that I do are in fact immediate one-stage surgical protocol with the transmucosal healing abutment being placed right at the initial surgery. This is wonderful from the patient's viewpoint. They are told, we're going to give you local anesthetic one time, we'll do the extraction, the implant placement, placement of the abutment, and 9 times out of 10 or better, we can do all that at once, and therefore you will not need any further local anesthetic for the balance of all your surgical follow-ups and your restorative procedures. We should not underestimate the power of that, and patients love it, and subsequently, we love it too. On occasion, I will submerge. Here's a tooth we had to remove. So if you've got a fairly large peri-implant void, you can handle this in a number of ways. You may want to graft and even put a membrane on this, release the tissues, and get primary closure. So on occasion, we will submerge. I did in this case, and there's a result of that. We never end up needing ridge laps with these wide diameter implants. Here's a different case again. That's this case, sorry. Here's the radiographic story. Submerged with initial placement. Now we get initial stability here with the circumferential lateral bone contact. We don't worry about apical stability. So we're generally going short of the apex of the extraction socket. We want these implants to be a couple of millimeters lingual to the facial bone, and we like them to be usually submerged a couple of millimeters on the lingual or interproximal bone. And this is showing you that case 3 months after restoration. So this is a 9 millimeter length implant by 8 millimeters in diameter. And even if it was 7 millimeters long, I'd have no concern about crown to root ratio or surface area because of the width. Let's look at the way I do it 9 times out of 10. We do it as a one-stage surgical protocol. Let's look at a mandibular case. Here is prior to extraction. We routinely do atraumatic extractions, as we do with all extractions where we want to place implants. We want to preserve the circumferential bone. Here's what the osteotomy can look like just prior to inserting our implant. And again, we want to keep that implant, as I mentioned, lingual to the facial bone and a couple of millimeters subcrest. Here it happens to be taking an implant that's 9 millimeters in diameter and 9 millimeters in length out of the vial. You can see it comes with a pre-attached implant mount. And you see the general positioning here. Here, this happens to be an external hex platform. These implants come with a Straumann type wide neck prosthetic attachment, or it comes with a Nobel Biocare-like replaced trilobe type of attachment. I'm showing you the cases where I have a longer term follow-up, and I started with the external hex. I am now using the IT version, which is the Straumann-like wide neck attachment. But we're talking surgery here, not so much prosthetics. Here again, I'm doing a one-stage surgical protocol, placing this 4mm tall healing abutment. As you can see where we are relative to position to the soft tissues, about 3 to 4 millimeters, subgingivally through the platform of the implant.